So what is a spinal emergency? So basically we define this as any kind of problem or lesion where really a delay or incorrect treatment will leave the patient either with a greater chance of progression or a less likelihood of getting better. So these are people that basically, whether if you don't treat them or you treat them inappropriately, in a relatively short amount of time, they will either get worse or their chances of getting better will go down. So broad causes of this. We see this basically divide the spinal emergencies up because what we worry about is not so much the spinal bones, but the spinal cord and the spinal nerves. So at the base of the skull, the spinal cord starts just above C1 and continues all the way down in most people till about L1 or L2. And then the actual spinal cord ends at that level, okay? And then all the nerve roots that come off the spinal cord, so basically all the function of the spinal cord below your belly button, which is around T12 or L1, happens from those nerve roots. So if you have an injury to the lumbar spine at L3 and L4, you're not going to have a spinal cord injury, but so it's going to be nerve roots, but the consequences of that injury may be exactly the same, okay? So there are important differences, though, because we classify the cervical, thoracic, and lumbar spinal cord down to about L1 or L2, wherever everybody's spinal cord ends. That's really the central nervous system. And below that is the peripheral nervous system. And like we talked about, the consequences or the neurologic deficits might be the same, but what is different is that people's spinal cords don't recover as well as people's nerve roots. So the timing of intervention of those things differs. So when you see an injury to the cervical spine and you see an injury to the lumbar spine, and it may be the same injury and the patient may have some of the same symptoms, the timing or the treatment may differ just because we know we can get away with a little bit more in the lumbar spine and we can treat things a little bit differently. So does that make sense? Okay. So specific causes. Well, a lot of things you guys see now, probably 98% of the things treated here are degenerative problems of the spine. Those can be lumbar degenerative disease, those can be cervical degenerative disease, they can be thoracic degenerative disease. Most of the degenerative disease you see is lumbar and cervical, and most of it is something to do with the disc. On the cervical and lumbar side, again, a lot of what you see is canal stenosis. So stenosis from a degenerative perspective occurs from joints, and joints hypertrophying and narrowing the amount of room that there is in the cervical and lumbar spine. So why don't we see the same thing in the thoracic spine? Why is it just C and L? Well, the thoracic spine is pretty stable. It doesn't move. It's not a level. There's no real joints there. Although they're joints, they don't really move. So you don't typically see a lot of degenerative disease in the thoracic spine because your rib cage is there and it's a solid structure. So the movement is in your neck and the movement's in your low back, and that's where you see degenerative issues for the most part. So trauma, hopefully we won't see a lot of trauma, but there are some traumatic things that will show up in the ER here that we probably will take care of. We see things like instability, we see things like gunshot wound and sharp penetrating wounds. We can see hematomas from trauma, and obviously post-operative injuries like iatrogenic trauma, post-surgical trauma. Infection we probably will see here, both post-op infection and infections that occur de novo or on their own. Those can be infections often of the disc. They can be infections of the vertebral body themselves, or they can be infections in certain spaces in the spine, like the epidural space. Those can occur after things like catheters for childbirth. They can occur after things like lumbar punctures, epidural steroid injections, like the infections, the fungal infections that you saw in the news. Those are epidural fungal infections. So they cause infection in the epidural space, but also caused by spread meningitic type symptoms and real bad problems like death, you know, from those gross contaminations. So other things that we'll probably see, tumors, especially metastatic tumors, and less likely primary tumors. As people live longer with cancer and radiation and chemotherapy treatments are better, we see more and more patients that have metastatic tumors to the spine. So they're occurring much more frequently now because people are living a lot longer and the rest of their systemic disease is much more controlled. Things like vascular malformations, these are less likely. These are things like spinal AV fistulas that can present with hemorrhages. And then there's other things like developmental or some acquired problems like syrinxes or Chiari malformations, which we'll talk about a little later. So this is a picture of the lumbar spine. These are the black things are little sutures. This is the dura. This is the covering of the spinal cord. This is the very bottom of the spinal cord here, and then you can see it ends about right here. And then these are all the nerve roots going down to control leg function. So this is probably about L1 or L2. So anything above here is a central nervous system injury, and anything below here is really a peripheral nervous system injury. So you're talking about small changes in area, and that's why things like MRIs in the middle of the night become so important to try to delineate these things. So one of the first things that we as neurosurgeons treated in the spine were lumbar disc herniations. This was all the way back. This is a New England Journal of Medicine or New England Surgical Society paper all the way back in 1934. So this is lumbar disc protrusions were known even before CT and myelogram really was present, and they've been treated for a long time. And really the treatment of those problems, the approach and the treatment have become more sophisticated, and the equipment's obviously become a lot more sophisticated, but the general approaches are very similar to what they were back in the 40s and 50s. Just very hard to see things back then. So Cauda Equina syndrome. So Cauda Equina syndrome is the peripheral nervous system injury. So that's that picture that we showed. That would be the bottom. So not the spinal cord part, but the nerve part. So this really is, in most people, sort of L1, 2, and below. Okay. So if you say someone has a Cauda Equina injury at L1, that's a little bit suspect because that patient, although they may have a lot of these signs, they probably have a spinal cord injury as well. But Cauda Equina syndrome is specific to the nerves, the group of nerves injured as a whole that come out of the spinal cord. Okay, so as opposed to that area above there, which would really be what's called a conus medullaris syndrome. That's really the area above there, and they're similar but a little bit different. So typically, what will you see if you see somebody in the floor in the office? These are patients that are complaining mostly of bilateral pain. They usually have some back pain. They usually have bilateral buttock pain. They usually have very similar sciatica type pain, but it's almost always bilateral. Okay. They also have anesthesia or decreased changes in their perception or sensation in their groin area, in their perineal area, and in their buttock down into the leg. So it can be both whole legs. It can be just the perineum. It really depends on what level. If it's L4, L5, it's going to be the lower legs and then the saddle. If it's L1, 2, it might be both whole legs. Urinary retention, this generally occurs from sphincter disturbance, and so the voluntary and involuntary reflexes that come down through the sympathetic and parasympathetic nerves that are on these Cauda Equina nerves are dysfunctional, and typically what you'll get is the bladder is just a muscle, right? When it loses its intervention, it just gets big and full of urine. So one of the things we see, or one of the things the residents would call me and say, hey, this lady has a big disc. I don't think she has Cauda Equina syndrome. She said she hasn't become incontinent. And I can tell them on the phone she's got a Cauda Equina syndrome because she's got a giant bladder on her MRI that's full. She's got 2 liters of urine in her bladder. So better than even getting a sonogram, post-void residual. So they said, oh, the patient went to the bathroom, no problem. And I say, oh, there's 2 liters of urine in their bladder. There's a problem. So it's one of the things that's very obvious on imaging. So we ask people about urinary symptoms, but it's not like these people are losing continence. In general, they have a very large bladder, and if it occurs quickly, they may never lose continence. The way they do lose continence is they get overflow incontinence. So the bladder gets so big it can't stretch anymore, and then urine starts to leak with coughing or anything else, or just on its own. Okay? So it's not like typically these people don't come in. It's more rare for them to come in and say, I just lost control of my bladder. It happens, but it's less rare. So usually they just have a big, atonic, denervated bladder. Okay? We will sometimes see fecal incontinence in these patients. It's almost impossible to see fecal incontinence without urinary continence. So I've never seen it. I've never read about it. So if you hear that, that's very suspect and probably not accurate. And fecal incontinence is usually the last thing people kind of hold on to. By the time they get fecal incontinence, they're in big trouble. And one of the things we check is obviously there's a rectal exam, and typically we're looking for just a reduction in sphincter tone or a reduction in sort of the reflexes like anal wink reflexes. Motor weakness or sensory loss is also common. Down lower, they can lose any of the reflexes, but below L4-5, we look for ankle jerks, we look for knee reflexes. That's typically L4-5, and the ankle is typically S1. So how do we look for this? I think my slide got messed up. But in general, plain x-rays are almost useless to find this. So nowadays, getting a set of plain x-rays is probably not the best first choice. And CTs, you may see it on a very good quality CT on a patient that's not real big. A contrasted CT just injects contrast into the venous and arterial system. So it's very unlikely you're going to see it with a contrasted CT. So the way we see it is by two different things, either by MRI, which is the gold standard, or by myelography. Myelography is injecting that same dye that you would inject into the IV into the thecal sac. So filling up that area that was tacked up with the sutures, filling that up. That all becomes white on imaging, and all the nerves look black. And that's how myelography is done. So it's pretty simple. That whole space, that subarachnoid space, fills up with contrast. That all looks white on CT or on X-ray. And then you can see nerve roots really, really nicely, especially on high-quality CT. In fact, the pictures you get from myelograms are often better than the image you get from a not-so-great MRI. So really, we're looking for MRIs or myelography. Those are the key things. So, and MRI is the test of choice. The only way we wouldn't do an MRI is if someone physically can't fit in the scanner because they'd be too big, because CT allows you to put bigger patients in, or if the patient has things like what? What things can't we put in the MRI? Pacemaker, anything else? What else? Well, metal implants are actually okay. So it's really, MRI is a magnet. It creates works by a magnet. It creates a big electromechanical field. So it's basically things that can be magnetized, which are ferric materials, so things made of iron, okay? And it's only things made of iron that aren't implanted, so that can move. So if you have an oxygen cylinder in the MRI, it'll move like a missile, okay? It's a very strong magnetic field, and as the MRIs get better, the magnetic fields get stronger, so it's even more important to be careful. So spine implants, even stainless steel that are made of iron, they're okay because they're in bone, okay? And the magnetic field's not strong enough to move that bone around, okay? A pacemaker lead, okay, is just sitting in the heart, so it's not implanted anywhere. So if you turn the magnet on, it's going to go through heart muscle. Any kind of neurostimulator, like an epidural stimulator, like somebody has any kind of neuromodulation device, sometimes for seizures, certain cochlear implants, things like that are, all those things are no-nos for MRI. Pumps are fine for MRI because it's a plastic catheter, and even though a lot of times they'll put a pack of ice on the battery itself just because it heats up a little bit. The other things that are shunts are okay. Those are all plastic, okay? And our newer shunts, those things actually have a little magnet in them. That's how we set the pressure. So we just reprogram them after the MRI scan because the setting can actually be affected. The mechanics of the valve is usually affected by the MRI scan, okay? But any implant, artificial knee, artificial hip, spine implants, those are all absolutely okay, okay? We used generally for implants in the spine, we use titanium, okay? That's not made of iron, okay? There's no iron in that. So it won't move even if it's free. So if you put a piece of titanium in an MRI scanner, it's not going to move around even if it's free. But we use that versus stainless steel not because of it moving, but stainless steel, when you do an MRI, has huge artifact on the imaging. You can't see anything. And titanium has much less. So we use titanium not because it's not ferromagnetic and it's not moving, but because we can see the images better. So that's CT is the same thing. On you image stainless steel with a CT, all it looks like is a big starburst pattern. It's all artifact. But the titanium implants look much better. And in the hip, things like that, you don't usually get a lot of CTs and MRIs post-op because they're all stainless steel. In the spine, we see other levels involved, and it's not like you do one hip and that's the whole problem. There's other things involved. They're close proximity, so you want to make sure you be able to image things after surgery. So anyway, so this is a nice MRI. This is a sagittal view. So the patient's belly button's here. This is the bottom of the lumbar spine. This is L5. This is the S1 level, the beginning of the sacrum, okay? This is what I was talking about. This is the spinal cord. It ends right here. So this is L5, 4, 3, 2, 1. It ends right, this one's even a little high. It ends at the kind of the top of L1. And these little things that look like a horse's tail are the Cauda equina. That means horse's tail, okay? And that's how they got that term. These are the lumbar discs, okay? And this, you see a giant fragment that's the same intensity as this material. And here you can see it right here. So when you're looking at this view, this is a person laying heads up here, feet are down here, belly button here, back here. When you're looking here, so when you're looking at a lumbar MRI, imagine the patient's feet are facing you and their nose is up in the air. So this is the right and this is the left. And that's the convention that's always used. Okay? Somebody came up with that a long time ago, and that's just the way it gets done. So the left is right and the right is left. So this is a more right-sided problem. In general, for a disc herniation to cause Cauda equina syndrome, about 75 to 80% of the volume of the space there needs to be taken up. You can have a big disc herniation. It can take up 70% of the space or 60% of the space or even 80% of the space. Patient can just have some leg pain or back pain. But to really, if somebody would get stuff from the ER, they say, well, they have a Cauda equina syndrome, and they really have a fairly small disc, 50% disc herniation, not like this. This is taking up almost all of the canal. You can see kind of no white material here. The white's the spinal fluid, so you can see almost none here. It really needs to take up about 80% of the volume of that level before you worry about emergencies. So this is an example of the same kind of problem. This is a blockage at the spine. This is at the level above. So this is at L4-5. This is L5-S1. Same pictures. This is a sagittal image, and you can see. But here, there's nothing really coming from the front. There's more stuff coming from the back, right? Closing it down, and you see the same thing here. This is degenerative stenosis where the joints back here, the facet joints, hypertrophy, they get bigger, and it narrows the space here. So you don't see anything really coming from the disc up here, but it's all coming from the back where the joints are. Okay? Most people with lumbar canal stenosis, 99%, do not have symptoms of Cauda equina syndrome because they acquire the problem slowly. So one of the things about the nervous system is it can accommodate a ton of pressure and stenosis if it happens slowly. If it happens quickly, it's a lot more likely to produce symptoms and a lot less likely to be tolerated. So how do we manage these patients? Typically, if this is a picture of a retractor system. This is a lumbar microdiscectomy. This is a view through the microscope, sort of looking at the muscles before the lamina is identified here. So typically, what do we do? In general, when people have Cauda equina syndrome, usually the treatment involves some type of laminectomy. In general, it can be done through a hemilaminectomy. It can be done through a full laminectomy. But microdiscectomy techniques usually are not used because the chances of the patient getting worse from that approach is a little bit higher. So the safer thing to do is actually make a little bigger bony opening so that there's a little more room to work, because it's already, the nerves are so tight, you want to open up a little bit more room to decompress the nerves before you start trying to take that disc out. A lot of times, if you do microdiscectomies, people will see either incomplete decompressions where you take pieces of the disc out but not the whole thing. You get a post-op MRI, patient's not better, and you still have pieces of disc there. Or because the dura is so taut and tight, when you're manipulating that disc, you get a leak. You get an injury to that lining, and so you get a spinal fluid leak. And that can be tough to fix, and then you really have to do a bigger decompression to fix it. So in general, And a lot of times we've even moved for really big disc herniations in people that have real bad symptoms. We've even moved to doing fusions up front in those patients because you get such a better exposure, and we've seen the patients get better so much faster, and the complications, even though it's a longer surgery, it actually ends up taking less time because the removal of the disc is so hard when you do a small bone opening. It's just so tight in there. So one of the things you always hear about, and one of the things if you see legal cases that get presented is, well, how if someone comes into the ER, how quickly do those patients need to be treated? So these are for Cauda equina syndrome. These are for the peripheral injuries. Okay, so there's been a couple people that have looked at this, and in general, what they've done is look at how quickly people that have surgery get better. The first study that really, not the first, but one of the most recent that has looked at this, there's one other, is basically what they described early surgery as surgery within 48 hours. Okay, so that doesn't seem that early, but they mean 48 hours of injury. Okay, so if you're working at a tertiary facility or a bigger community hospital like here, you may see somebody at the outside hospital. They may have happened a day ago. They don't come into the outside ER until their bladder dysfunction starts, which is 24 hours after injury. So by the time we see them in our ER, they're 30 hours into their injury. Okay, so it's not like these patients are being flown by helicopter like if you have an acute MI or if you have a big trauma. These are a lot of times people that will actually walk in, maybe not well, but they'll walk in, they'll stay at home for a while. So getting them in and looking at things like 4 and 8 hour windows are almost impossible for these folks. So it's not 48 hours from when they hit our ER, it's 48 hours from the time of the symptom onset. And sometimes when those symptoms started can be tough. They might have disc symptoms for weeks on one side, and then all of a sudden they go out and they do something, or they move around the wrong way, and all of a sudden then they hit bilateral symptoms and they have some urinary dysfunction. And it's really that time that we're talking about, not the weeks before that. So, and what they did find in this study, once you lose your autonomic, your bladder function, and your bowel function, usually those patients have worse outcomes. So people that have bladder dysfunction or bowel dysfunction or both, those are people we really try to get into surgery and get fixed as quickly as possible. Go ahead.
Now, for those patients, at that point, would you just do a fusion?
So we have been more recently, just because to get a big disc herniation like this, a massive disc herniation, especially when you haven't had previous surgery before, it implies that something else has been injured. It's not just the disc that's been injured. And in retrospect, what we've seen is that when we go back and look at those patients' MRIs from presentation, they've had other things like facet injuries and things like that, or they're more traumatic injuries than just somebody that has, say, a herniated disc. And also what we've seen is because we do pretty extensive laminectomies for those patients, they've had a higher post-operative instability rate that have need to come back for previous surgery. They also have a higher rate of reherniation of disc. So that's the reasons to do fusion up front, because it eliminates those things. One of the reasons not to do fusion in those patients is that typically we're doing that surgery at 8, 9, 10, midnight, and trying to do a fusion is much more complicated at midnight than it is at 8 a.m. So a lot of times what we'll do is that patient may come in at midnight. We may say, let's start at 5. And so the normal people come in an hour early, or however you manage it. And that way it's sort of a compromise between sort of doing it as an emergency and doing the right operation. So, but we do occasionally do fusions in the night. It's uncommon, very uncommon. I can count on one hand how many I've done in the last 10 years. So this was another story. They tried to push the time to 24 hours, and they basically found that the same exact thing. The people that are beyond 24 hours, their bladder function is less likely to return. They don't have as good of an outcome. So in summary, we say that definitely before 48 hours and if possible before 24 hours are really the time periods we're looking for. Okay. So let's talk about cervical disc herniations and spinal cord compression now. So this would apply to the cervical disc. Like I said, thoracic discs are much less common, especially acutely. But this is now central nervous system injury. So this is spinal cord itself. So most of these are usually traumatic. There can be a bunch of different mechanisms. When we talk about cord injuries, we talk about complete cord injuries or incomplete cord injuries. And I listed below incomplete. So what is a complete spinal cord injury? A complete spinal cord injury means that the patient has no function below the level of the injury. Okay? I can tell you that what people, the contemporary thinking about complete spinal cord injuries is that within the first 48 hours, no one should be called a complete spinal cord injury. So unless they have a spinal cord transection, meaning the spinal cord is actually not attached anymore to itself. So there are some things that we call complete spinal cord injuries, but in general, because very quickly reflexes and motor function, sensory function can come back in the first 12, 24 hours. So in general, we try not to make a determination of a complete spinal cord injury for the first 48 hours. Complete spinal cord injuries are not going to be the stuff we see here. Okay, it's not appropriate. That's a trauma center type thing that you want to take care of those patients for, and a lot of it's for rehab purposes or for pulmonary purposes. Many of those patients end up getting trachs, things like that. So things we will see here, we will probably see some incomplete spinal cord injuries. The most common incomplete spinal cord injury that we see is what's called a central cord injury. In general, those are usually a little bit older patients, meaning late 50s, 60s, 70s, 80s, who have pre-existing cervical spine stenosis. They may know they have cervical spine stenosis. They may not know it. They may just have had some neck pain. Those people have a minor trauma. They hit their head coming out of the shower. They fall and have a I've seen these old people in the ER that have injuries where they fall out of bed or fall out of, and those people, they have that tight canal anyway. They don't have enough room to tolerate that kind of injury, and they have a spinal cord injury as a result of a trauma that you wouldn't expect would cause a spinal cord injury, but it's because their normal spinal cord is already sort of at a critical point. Okay, and those patients, central cord injuries, a lot of times those are patients that may even walk into the ER, because their leg function is usually pretty well preserved. Okay, it's usually mostly their arm function. It's bilateral arm function. A lot of times they either have loss of function of their hands, they can have really bad burning of their hands. That's a common thing. Loss of sensation, a lot of numbness. So that's the kind of stuff those people will complain of. There's a couple other incomplete spinal cord injuries that we talked about. An anterior spinal cord injury, that's usually from a stroke of the spinal cord. You usually don't see that from degenerative disease or trauma. It can happen. A Brown-Séquard syndrome, which is usually from a knife wound. It's a more uncommon. It's a hemicord transection, so half the spinal cord kind of gets hurt, the other half kind of gets left alone. But because of the way the spinal cord fibers cross in the spine, usually the motor function is affected, and pain and temperature sensation is affected on that side, and fine touch is affected on the other side because of the way fine touch fibers cross. So that's called a Brown-Séquard syndrome. You can have a mix. You can have an injury where you have some examples of central anterior Brown-Séquard, but doesn't completely describe by one, or a posterior, and that's also usually either an injury from surgery, tumors can cause that, or a stroke can cause that as well. A stroke is more likely in the anterior because there's one big artery that runs down the front of the spinal cord, and if that gets occluded, there's no reserve. The posterior, there's two big spinal arteries, so occluding one usually doesn't cause a problem. So this is the same exact thing that we looked at, okay? But now you see here, nice spinal cord, brainstem spinal cord interface. This is C2, this is C3, 4, 5, 6. You see some disc here, you see this white look of the spinal cord here where it's narrow, okay? We call that T2 signal change, or myelomalacia, or edema. So anything, these T2 images, where the CSF looks white and the spinal cord looks gray here, any kind of spinal cord injury will show up as a white spot on the MRI. So it's real obvious when people have those. And this is actually probably, although it says acute cervical disc prolapse, somebody else made this slide for me. This is probably a more chronic injury looking at it, because if you look at the color of this here, this is very dark. This is not a new disc herniation. This is somebody with pre-existing stenosis who probably had a central cord injury. And this is probably not right. So it's a minor detail, but important. So these patients are almost always treated by some type of anterior cervical procedure, either an anterior cervical discectomy, decompression. There's a bunch of different ways that we can treat it. Other things in the cervical spine, these are tumors. This looks big. These are centimeters. So 2.5 of these gradations is an inch. So 1, 2.5. So this is an inch from here to here. So this is about 1 1/3 inches, something like that. This is a large tumor. Again, this is the tumor from the first slide I showed you where the opening was. That was the tumor sitting in there. That's the reason it was open like that. And that tumor was sitting in that space, producing symptoms of both spinal cord compression and nerve root compression. And oftentimes there are tumors called ependymomas that grow from the little area of the spinal cord that keeps it sort of planted there, and that's a common site that these tumors grow. So metastatic tumors, like I said, are much more common. They occur in almost 10% of cancer patients now. About 5 to 10% of new cancer patients present with cord compression, and oftentimes this is their first diagnosis of cancer. And then based on that, we look for the primary because it's almost always metastatic disease to the spine. These tumors don't start in the spine. Oftentimes, pain is the first symptom these patients will see. It can be localized, just back pain. It can be sort of slow back pain that gets worse and worse over time. It can be neck pain. It can be pain like a disc or pain like stenosis where people get claudication, where they have trouble walking distances. It can be just isolated leg pain. So it can look just like other things. About 3/4 of them have some type of neurologic deficit when the diagnosis is actually finally made because they get sent to physical therapy. They get sent for, especially the patients that don't have a cancer diagnosis. The patients that already have a cancer diagnosis get picked up much more quickly because the doctors will know, hey, new back pain in someone with cancer, Dr. Reefer is going to treat that differently than someone that just has back pain in the office that doesn't have a cancer diagnosis, obviously. The median time from symptoms to diagnosis is about 2 months for these patients. And again, this is somebody else made this, but a lot of times we'll see these, and it's true. What happens is radiation gets done Monday through Friday. Radiation doesn't get done. So even for acute patients, the radiation schedule for spine mets is it's 10 treatments Monday to Friday, 2 successive weeks with Saturday and Sunday off. And a lot of times what will happen is, well, we'll say, well, we as radiation oncologists think this patient has a big tumor, but you know what, let's try the radiation, see how it works. And what will happen is they'll do the five radiation doses. Now it'll be Friday afternoon when the patients, they'll call the office after their 5th, the radiation's starting to kick in, the swelling's starting to kick in, and they say, you know what, I'm worse, and the radiation oncologists aren't there, and they go, well, now we call the neurosurgeons and try to figure out what to do, because I don't want to wait till Monday to see them get worse. So this is an MRI. This is a metastatic MRI. You can see this is the third kind of pattern I've shown you. The first was a compression from the front. Remember, that was the disc, right? Second was compression from the back. That was the stenosis. This is circumferential compression. So if you see here, there's tumor invading this whole vertebral body. See how it looks different than the other vertebral bodies? It's kind of this soft, kind of mossy look to it. That's a bone that's been invaded by tumor, okay? And then the tumor is here in the epidural space, compressing the spinal cord, so there's very little spinal cord. Here's the spinal cord here. You can see a little sliver of spinal fluid, but you can see the tumor all around the spinal cord like this, and there's even tumor that goes into the rib head here. So this is a very typical presentation of a vertebral body metastatic tumor. This is a patient with a small cell. So small cell is a cancer that is very radiosensitive, and if we see patients with small cell that have mets, they get radiated first, and they almost all get better. So almost none of these patients, the only time we operate on small cell is when they present as the first diagnosis and we didn't know they had small cell. So almost all these tumors are treated with small cell. There's groups of tumors that are very radiosensitive. There's groups of tumors that are very radioresistant. So we use that understanding, if we know what kind of tumor it is, and then how bad off neurologically the patient is to try to decide whether we operate, whether we give chemotherapy for things like multiple myeloma, or whether we do radiation therapy for things like small cell carcinoma. Yes?
On that slide,
yeah.
I'm not sure what the 852 refers to.
I don't know either. I'm on board. I don't know either. I may have messed it up. Who knows? So the thoracic spine is the biggest. that's where most of the Mets are seen, just because there's the most amount of levels. Okay, cervical and lumbar spine are second. We see Mets, though, you can see here, this is a big kind of ugly metastatic lesion to the craniocervical complex, and these are actually common because the craniocervical complex is a lot of tissue, and so there's a big chance of sort of hematological seeding from the blood, and that's the chances of getting these tumors in the spine are just related to how much blood is going to them. So the bigger areas get more blood, they have more chances of getting Mets when somebody has active cancer. These patients are usually treated with a lot of pain, and sometimes this is an very old fusion technique, but typically combination of radiation with some type of fixation is the best treatment for these. Fixation alone doesn't treat the tumor. Radiation alone doesn't treat the patient's pain. These are patients that sometimes can't even turn their head because they're in so much pain. They get fused the day after their incision. Even though they have this big incision, they're so happy because they're not sitting there in fear of trying to move their head. So this is a sacral tumor, a metastatic tumor down here, and we see those as well. So very top of the spine to the very bottom of the spine. So like I was saying, how do we manage these? Well, almost everybody with active spinal cord disease with compression of the spinal cord or nerve roots gets some type of acute steroid therapy, and that can be very helpful. You can see people that come in with bad motor and sensory deficits that in a few hours of getting high-dose steroids get better. This is not like a trauma where you talk about giving some type of steroid protocol and it's controversial. Everybody with cancer and with metastatic tumors or non-metastatic tumors, steroids are very effective. So most of what you hear, like as an ER nurse, is this controversy over steroids and spinal cord injury, but those are traumas, and they're completely different from non-traumas. Like I said, because if obviously if you have an injury where you transect your spinal cord, you can give as many steroids as you want, it's not going to do anything. But these patients they're usually incomplete, they have mild to moderate deficits, they can have more severe deficits, but typically the steroids very quickly, especially IV steroids, make a significant difference in them. So you may come in and say, hey, this patient has an emergency, they're going to need to go to the OR tonight, and we say, you know what, it's 8 o'clock, the patient needs a pretty big operation, I'd rather do it first thing with the regular staff. Let's just see how the steroids work over a few hours. If they don't work, we'll take them back and just decompress them tonight and do a bigger surgery at another time. If it does work, they get one operation instead of having 2 smaller operations, because we can't do the big operation in the middle of the night because we don't have the right stuff, the right people, and works out better for the patient. So even patients that are having elective surgery for tumors, whether they're primary tumors or metastatic tumors, we often give steroids to, so you'll see them come in on steroids already because it makes the surgery a little bit safer, just a little bit more leeway. We use different types of radiotherapy for spinal tumors. We use traditional XRT, which is typically, like I said, 10 sessions, 5 sessions per week for 2 weeks. And then we will use things like CyberKnife or radiosurgery, which can be 1 session, it can be 3 sessions, it can be successive, they can be broken up. People are really just kind of exploring how these things are done. And when I say conservative treatment, I usually mean palliative treatment. So it's not really conservative treatment, it's really palliation. So there's a lot of different surgical options for patients with tumors. Things like simple laminectomies, vertebrectomies where we remove the entire vertebral body. We do decompressions with instrumented fusion. Oftentimes we'll embolize these patients preoperatively. A couple of the tumors that we embolize almost always are things like renal cell Mets. They're typically very vascular, very bloody tumors. Prior to embolization, we would do a surgery, we might lose 5 or 6 or 7 liters of blood during surgery. And just with embolizing them, we may reduce that to 1 or 2 liters. So it makes an enormous difference as far as intraoperative safety and intraoperative efficacy goes. Vertebroplasty, do you guys know what vertebroplasty, kyphoplasty, have you seen that? Where people use methyl methacrylate to inject the bodies. We do that for cancer patients. It is not as efficacious as doing it for people with osteoporotic fractures, which is the main indication, simply because in an osteoporotic patient, all you're doing is filling up that bone loss, that kind of osteoporotic bone, with something else. Well, the tumor's sort of already done that. So there are devices where you can actually go in and remove some of the tumor and kind of suck it out with a device but those are all newer devices or experimental devices. People are doing vertebroplasties and kyphoplasties for these, but they are less common and less efficacious also. So when do we do surgery? I talked about this a little bit. Almost everybody that gets surgery has some type of spinal cord compression or functional deficit. Oftentimes we'll do surgery just to get a tissue diagnosis, whether that's when I mean surgery, either biopsy or some type of open biopsy. For radio-resistant tumors, so some of the radio-resistant tumors, renal cell is a very radio-resistant tumor. Certain types of lung cancer can be radio-resistant tumors. Previously irradiated patients, so if someone has breast cancer, they've been irradiated, and then they come back with Mets, and they can't tolerate more radiation, those are indications for surgery. Neurologic progression after XRT. Some of the contraindications, if people have multi-level disease and multiple levels of spinal cord compromise, poor functional status, or if patients really have a paraplegia or quadriplegia, which is more than 24 or 48 hours. At that point, doing anything to fix the canal stenosis is probably not going to regain spinal cord function. So especially now if it's a 24-year-old guy who has testicular cancer, who has Mets, who slips and falls at home and gets quadriplegic and comes in and is 20 hours out, it's different than somebody who's 85, has metastatic, stage 4 lung cancer, who slips and falls at home and is paraplegic. Obviously you treat the patient's disease and the patient, not just the area of stenosis. So this is a vertebrectomy. We showed you, this looks like the slide. This is tumor in bone, normal bone, normal disc with tumor in it. You can see here one of the things we see. For whatever reason, tumor doesn't grow into disc. Tumor really doesn't grow into the disc. The disc is sort of left alone from the tumor. So there's always usually a nice plane between the disc and the tumor, which you can see here. So after taking this out, this is a titanium cage that we actually, these long strips of bone are from the rib that we break into pieces from the approach. This is via transthoracic, this is via thoracotomy to take this out. And then we use this. You can see this is now sitting right here. So sometimes we'll do this and do nothing else. Sometimes we'll supplement that with some screws from behind. Sometimes we supplement it with a plate from the front. There's a bunch of different ways that can be done. So how do we justify sort of operating on tumors? The best study was a study done by Guy Patchell, and he looked at direct decompressive surgery with fixation. So for some patients and there was a lot of this was, the treatments were different, but it was direct surgical resection and fixation. So not resection of the entire tumor, but just decompression of the spinal cord, fixation of the spinal cord so it's solid, followed by radiotherapy, randomized against radiotherapy. And what they found was that, and these are all single lesions, what they found was, and a couple things here, a couple things they excluded, like I talked about, some of the radio-sensitive tumors that were going to get radiation either way that you shouldn't operate on were excluded. Fixed neurologic deficit for more than 48 hours, somebody that had previous spinal irradiation, somebody that has brain mets or a very short survival were excluded. And basically what they found was that surgery plus radiation therapy, so this is both, versus radiation therapy alone for those tumors, improved walking. So these patients were able to walk for half a year, almost half a year versus 2 weeks. They were able to keep their continence for half a year versus 2 weeks. They increased their functional ability. This is a spinal cord scoring device to look at functional outcome. They needed less steroids and opiates. They lived longer, and their hospital stay wasn't any longer. So this trial was actually stopped. This was a randomized trial. Actually, such a wide diversity in the patients that they actually stopped the trial early because they couldn't justify randomizing people anymore. So before 2000, we didn't operate on a lot of metastatic tumors because we didn't have really good evidence that it, so we kind of looked, said, well, yeah, that person would be good, and that person maybe just radiate, but we've become more aggressive since this because I think we have very good level 1 evidence now that says surgery is probably very helpful for these patients. Primary tumors, so non-metastatic tumors, they can occur in the different spaces. They're usually either within the spinal cords themselves. Those are the intradural intramedullary tumors, so intramedullary within the spinal cord substance. They're either ependymomas or astrocytomas. There's a couple other things that are less common. Or intradural tumors but not inside the spinal cord itself. Those are usually schwannomas, meningiomas, we will see those. Now, this is an example of the tumor that I showed you before. You can see this big tumor here pushing the nerve roots back, all the nerve roots here. Okay, this is the tumor. You can't even see the nerve roots yet. So these are fun to operate on because the patients do really well, and they're benign tumors, so you take it out and it's cured. So it's one of the nice things we do. This is a tumor that's an intradural tumor, another shot of it. Some of these, I just sort of showed this to say that not only taking this tumor out, but if you do a long enough laminectomy, this is a long tumor, goes all the way from here all the way down to here. Do a long enough laminectomy, some of these patients also require fixation in the future. This is another complicated tumor. This is a craniocervical junction meningioma. This is somebody that presented with weakness of both arms and both legs. These also have some cranial nerve findings, so they get problems with swallowing, problems with tongue function, problems with handling their secretions, and that's how they found this tumor. You can see here, this is the bottom of the cerebellum here. This is all tumor here. This is spine. This is brain, so, under the tumor. This is a ependymoma. Let's see. This is all under the microscope. Same dural tack-up sutures here. Tumor sort of getting cored out here. This is the other end of the tumor. You can see the normal spinal cord, normal nerves down here. This is all tumor. And this is post-resection. So you see where the tumor was up here. This is bottom of the spinal cord and spinal nerves all here. These all kind of look very flat because the tumor's been pushing on them for so long. So, you know, if acutely you put a disc in somebody this size, they would never recover. But because this tumor has been growing so slowly for so long, this thing can get huge, and people can have very mild symptoms. So long, slow process, neurologic system handles really well. Quick process, not so well. Infection, we talked about a little bit. Vertebral bodies can get infected, the disc space can get infected, the epidural space can get infected. We see this post-op. A lot of times we see it, that'll be the most common thing we see is our own infections. And the infection rate for the stuff we do here should be probably about 2%. So if we do 100 cases, we'll see 2 or 3 infections. De novo infections of the disc space and spinal canal and the epidural space, epidural abscess, which is a lot of times what we worry about in the emergency room, those occur in very specific groups of patients. They occur in IV drug users. They occur in immunocompromised patients. That's pretty much it. So if it's a young person who's healthy and they get an epidural abscess, 100% of the time they're IV drug users of some kind, or they were IV drug users. And literally I'll have people that deny it for 2 years, and they'll tell me that they're an IV drug user 2 years after like the second operation we go to do to stabilize them. You know, finally will come out that they were using IV drugs. We saw it a lot at Presby because we had all the transplant patients. So we see a lot of the transplant patients get infections because they're chronically immunosuppressed. In this hospital, what we'll see, we will see some in, nowadays you see more in patients with things like psoriasis, rheumatoid arthritis that are taking autoimmune drugs that are also for the purposes of suppressing their immune system, but leave them more likely to have these kind of problems. These are still relatively rare problems. The only other kind of healthy patient I ever saw this in, and we figured it out afterwards, and it ended up getting published. There was a girl who was pregnant who had an epidural abscess, a small one that we ended up treating just with antibiotics. She, and it came out later that she was getting really high doses of progesterone for fertility treatments, and a couple other cases happened across the country, and then they wrote an article saying that it's a relative immunosuppressant, the high doses of progesterone. So sort of never, I was like, this is very weird to see this, and then she was on some new protocol where she had failed the regular doses, and they put her on some super high protocol, and had a couple other patients with these weird infections. So How do we diagnose these? A lot of times these are just biopsies, sometimes CT guided. They're usually things that we don't even do as surgeons. These are usually the radiologist biopsying these. And of all the biopsies, only about 50% of them end up growing things, so a lot of people end up getting treated. Biopsies more not to say that there is an infection, but to say if we can focus on one drug or just to see if we can get a specific bug to figure out how to treat it. If we don't, we just treat it with broad spectrum, typically. And these are long-term antibiotic patients. So these are 8-12 weeks of antibiotics, usually minimum, when they get an infection in this area. Usually the patients that go to surgery are things like epidural abscesses, acute cord compression or acute spinal nerve root compression that are symptomatic. And then after surgery, they end up with long-term antibiotics as well. The antibiotics, these are just like any other infection. If you have a pimple, you pop it, and if there's a skin infection, you treat it with antibiotics. So just like that, any abscess gets treated by drainage, unless it's really small and not causing a lot of problems. And then after the abscess is drained, you put the patient on antibiotics to treat the rest of the tissue. This is a case of something we shouldn't see here, but this is very common in a lot of countries still in the world, is tuberculosis of the spine. It's called Pott's disease, and you see these bodies, and a lot of times these bodies will collapse upon themselves. They become unstable. These people have a lot of pain, and it's really a big problem in places like India, where there's a lot of tuberculosis still. Oftentimes people can have two problems. This is a patient that has two different lesions from lymphoma. And this is a bad discitis. I showed this just because it was similar to so this is kind of completely misaligned cervical spine. Some we straightened and fixated. And this was the MRI pre-op. You can see just like the stenosis that I showed before, you can see this big vector coming from the front and some from the back as well. It's another, this is a 35-year-old HIV positive gentleman with a history of IV drug use. He's got acute back and leg weakness. And you can see this is a non-contrast. You can see the mass lesion, and then on contrast, everything lights up here. So, and a couple traumatic things real quick. So you get the time. I did talk for an hour. So this is a bad cervical spine injury. This is nicely aligned now, but this is a very unstable injury. You can see here the T2 signal change in the cord here. This is someone that ends up having surgery. This is what we talked about. This is a hyperextension injury. So guy's in pretty good shape. He doesn't have a real bad problem. But you can see how stenotic his cord was, and then just a little bit of injury. So this was, none of this is new. If you would have gotten an MRI a week before his injury, this would have looked probably exactly the same. Even the signal change in his cord probably would have been the same. But he tolerated it because it was such a slow process, and that acute little injury, hyperextension injury, just kind of put his already at-risk spinal cord just over the past the point of no return. So somebody had actual laminoplasty to fix this. And then things like gunshot wounds, knife wounds that we talked about. Hopefully we won't see any of that stuff here. This is a bullet wound with a vascular injury. Talk about. This is actually a nail gun that we saw. Someone got shot through the mouth into their brainstem. So we save. Some of these images get saved because they're... But what you can see here is this is a steel, this is an iron nail. And you can see how much artifact this puts off. That's what I was kind of talking about, the artifact. So it looks like this starburst pattern. On X-ray you don't see it, but on CT you can see how much artifact there is here. So epidural hematomas. Most of these are anticoagulated patients. A lot of times they're patients on Coumadin that get epidural injections, and people forget to ask them that they're on Coumadin, or they don't wait long enough, or they have a vitamin K issue where they're even keeping them off the Coumadin for long enough doesn't get rid of the Coumadin effect. There's a variety of reasons. They're almost always traumatic, either from the pain doctors or from us, very rarely we'll see spontaneous epidural hemorrhages. They're almost always from arteriovenous malformations of the spinal canal, which are really pretty rare. This is a post-op epidural. It's a little bit harder to see. This artifact, this black stuff here, this black, see how it's all black here? That's an anterior cervical plate on MRI. So this is somebody that had a previous fusion, then somebody went back and did a posterior decompression years later, and all this stuff is blood closed under the fascia, so it's under tension. So once you open up this fascia, it just kind of comes out and decompresses itself. So this is somebody that didn't dry up well enough, or somebody that was on anticoagulant, on aspirin. Yeah, on aspirin. So we blame the aspirin, not the surgeon, right? Anyway, okay. Questions? Anything I can answer? That's a lot of material. I know. I just sort of wanted to give an overview of stuff.
How long should they be off anticoagulants before this procedure?
Yeah, so it depends what you're having. When I do open surgery, I don't typically take people off aspirin anymore because the aspirin really doesn't have that much of an effect. If people are on things like Plavix or Coumadin, obviously, Plavix is a lot more efficacious of a drug for platelet function than aspirin. We typically keep people off Plavix about 7 to 10 days if we can. For Coumadin, you just want them to be off long enough to be reversed, and it depends why they're on Coumadin. So if they're on Coumadin and they need to be on Coumadin and they're at high risk, like someone with a mitral valve, an artificial mitral valve is at super high risk for stroke, mechanical mitral valve, if they're off Coumadin, we'll bring them into the hospital, put them on IV heparin while they stop their Coumadin, and then do surgery, put them on IV heparin right after surgery, and then convert them to Coumadin in the next couple of days. For almost everybody else, even aortic valves nowadays, we just stop their Coumadin 3 or 4 days ahead of time. We check an INR in the morning in the pre-op holding area, and if that's below about 1.4, so 1.4, 1.5 not okay, 1.1, 1.2, 1.3 usually okay. The platelet drugs have a much longer effect than the drugs that work on the non-platelet effects, that work on the fibrinolytic cascade.